Good evening, everybody. Thank you very much for having me. I'm very excited to be here and talk with you all tonight, sharing a topic that I'm excited about and that's very close to my own heart, and that's global otolaryngology. And I'm hoping to provide an evidence-based update this evening with you all. I have no disclosures. Um, and a couple acknowledgements. One is Dr. Patrick Jean-Gilles. He is a head and neck surgeon and the director of the otolaryngology program in Port-au-Prince, Haiti, who I've collaborated with quite a bit over the years. And he's been a big mentor for me. And also to Dr. Fidelia Butt, who maybe in some part I'd like to dedicate this presentation to, who tragically very recently passed away, but was a huge advocate and champion for global otolaryngology and was also a big mentor. And so I want to kind of frame our discussion this evening in terms of 6 questions that are going to be our roadmap for what we'll talk about. So the first is a little bit of background about what is global otolaryngology. Then we'll talk about why global otolaryngology matters. Then we'll talk a little bit about where we stand at the moment. So what's the global burden of disease and what's the workforce availability? We'll talk about some common pitfalls and evidence-based best practices for global otolaryngology. We'll discuss the path forward and what the future might look like. And then we'll talk a little bit about how we can potentially try to incorporate global otolaryngology into our own practice here at Stanford. And then one caveat is that this is obviously a huge topic and a lot of ground to cover in a pretty short period of time. So it'll be pretty much like the 20,000 foot view of things, but I'm happy to kind of delve into the weeds or go into questions if we have some time at the end. So first, what is global otolaryngology? This is kind of like one of those buzz terms we hear a lot: global health, global surgery, global otolaryngology. But what does it mean exactly? So for me, I'm someone who feels like in order to understand a topic, I feel like I need to understand its roots and where it comes from. And so global health has its strong roots and origin story in public health. So along those lines, does anybody remember what this is a picture of? Kind of drawing back on our med school days. Yeah, nailed it, Alana. Way to go. Yeah, this is the 1854 London cholera outbreak as mapped by John Snow. Not that John Snow, that John Snow. This is like one of the first and earliest recorded public health investigations, finding a source and cause for this disease outbreak, and then a direct policy intervention in terms of closing the pump and seeing the disease outbreak recede. And so since then, global health has evolved and public health has evolved a lot too. But in the past decade, about 10 years ago, the Lancet Commission came together and came up with a unified definition of how we describe global health. And so I wanted to just take a minute and go over that all together. So global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health disciplines, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level care. So a couple of things from this definition just to focus on. One, we're talking about achieving equity in health for all people worldwide. So yes, when we talk about global health, we're oftentimes thinking of the international sphere, but it also directly applies to our own backyard and communities here at home. The other thing as well is we're talking about population level strategies, so systems level issues to address the population as a whole, but we're also really talking about the care of individuals. So it's all kind of incorporated under this very large umbrella of global health. So what about global surgery? What about global surgery? Where does that come in? So global surgery is a more recent offshoot of global health. If you had to say that there was like a start time to global surgery, you may be able to trace it back to 1980. And that's when this gentleman, Dr. Halfdan Mahler, he was the 3rd Director General of the World Health Organization. He gave a speech called Surgery and Health for All. Here's a brief quote from that speech in which he said, "The distribution of surgical resources in countries throughout the world must come under scrutiny in the same way as any other intellectual, scientific, technical, social, or economic commodity. The era of only the best for the few and nothing for the many is drawing to a close." Seems very straightforward and pretty routine for us nowadays, but really in 1980, this was pretty groundbreaking in terms of trying to build and disperse surgical infrastructure around the world. 2008, I think, marked another major turning point in global surgery. And that's when doctors Paul Farmer and Jim Kim, who were both the founders of Partners in Health and um, really leaders in the field, published an article called Surgery and Global Health, A View from Beyond the OR. In that publication, they called surgery the neglected stepchild of global health, which some of us may have heard before. And it was really a call to galvanize the medical community to rally around global surgery in the global health sphere. And then I'd also be remiss if I didn't just take a moment and recognize the recent passing of Dr. Paul Farmer, which is really sad and a tragic loss for this community. Okay, so 2015, I think, marked another major transition and kind of the last major milestone in the global surgery saga. And that's when there was a publication by the Lancet Commission on global surgery. And I would say that, if 1980 marked the kind of birth of the global surgery movement, and 2008 kind of galvanized support, I think this 2015 is what really catapulted it or catalyzed it into a academic discipline in and of itself. And of the number of articles that we'll talk about tonight, we'll see that the vast majority have been published since 2015, as this was really kind of like a major inspiration and call for academicians around the world. And so this commission was one of the first major interdisciplinary research efforts to evaluate global access to surgical care and also to evaluate the economic and healthcare consequences with regards to lack of access. It laid out a series of policy directives at both the national and international level that could be done to improve surgical access. And we'll go into details throughout the presentation and kind of loop back in different findings from this commission. And then I just want to also draw attention to the list of authors from the 2030 Lancet Commission report. We'll see that it's a pretty short list of authors, but two of the authors, Dr. Mark Schreim and Dr. Blake Alkire, are both otolaryngologists. And I think that that's pretty notable because of this pretty small cadre of authors. To have two otolaryngologists, I think is maybe an overrepresentation of our field. And I think that that just goes to show that we actually have like a really rich and deep history and footing in the global surgery realm. And so when we say, when we're talking about global otolaryngology, in terms of kind of tying this in again with a cohesive definition, there's not really like a publication, or if you look under the dictionary, there's no clear definition of this, but I would argue that we can apply the same definition that we're using for global health and global surgery for global otolaryngology. So that definition would look something like this. Global otolaryngology is an area for study, research, and practice that places a priority on improving otolaryngologic health and achieving equity in otolaryngologic health for all people worldwide. Global otolaryngology emphasizes transnational health issues, determinants, and solutions as a synthesis of population-based prevention with individual level care. So that's a little bit of our background into global otolaryngology. So why does global otolaryngology matter? Why should we care? So I think that there are two major arguments that we can make. There's certainly more, but I think the two that we'll touch on this evening are, one, there's a direct link between economic development and global health. And two, I'd argue that there's certainly a moral imperative. So the economic argument goes something like this. Healthcare is a good investment. Kind of simple, but we'll kind of delve into that. So in 1993, there was a report. In 1993, there was a report published by the World Health Organization called the World Development Report. This was really one of the first publications in general to make this direct tie between economic growth and economic development and the healthcare of a community. And so they theorized that there were four main ways in which the two were linked. So the first was that healthier countries had increased worker productivity. Next, they had improved utilization of natural resources. They had improved education investment in the future just by virtue of the fact that their population was able to attend school, achieve higher levels of education because they were healthier. And then it also freed resources away from having to take care of sick individuals and invest into other areas of the economy and growth. So those are the theoretical arguments. But what does this look like in terms of tangible facts? How has this been connected? So from 1970 to 2000, a number of modeling studies have suggested that approximately 11% of all economic growth in low and middle income countries is directly attributed to reductions in mortality. And then from 2015 to 2030, this is from that Lancet Commission on Global Surgery, from 2015 to 2030, treatable surgical conditions are estimated to result in a loss to the global economy of $20.7 trillion. That's about 1.3% of the world economy. And more than half of that is expected to occur in low and middle income countries. However, investing $420 billion now could help entirely curb those losses of 20.7 trillion. So yes, surgery is expensive, but investing $1 now could save us $20 in the future. Or for every dollar we save, would save $20 in the future. And the goal is certainly not to invest in surgery at the detriment to other healthcare infrastructure causes, but rather it's just to make the argument that surgery needs to have a seat at the table and that any functioning healthcare system requires both medical and surgical practices available. So that's the economic argument. The moral imperative argument is basically based on the fact that surgery is important and people don't do well without it. So about 17 million people worldwide die annually from conditions requiring surgical care. That's about 5 times the number compared to malaria, HIV, AIDS, and tuberculosis combined. The reason why that comparison I think is important, it's not to say that one condition is more important than another by any stretch, but it's just to contextualize because historically those 3 infectious disease conditions have kind of been the cornerstones and the pillars of global health interventions. So I think that when we contextualize that in relation to surgical conditions, it's just more ground for the fact that this is an important consideration. The poorest countries in the world constitute 33% of the world's population, but account for just 6% of all surgeries performed globally. And as of 2015, about 5 billion people were estimated to lack access to safe and affordable surgical care when needed. And even amongst people who are able to reach surgical care, about 81 million people annually will face catastrophic healthcare expenditures, even if they get that surgical care that's required. Okay, so that's the argument, at least in my mind, for global otolaryngology. And so where do we stand at the moment? What's the global burden of disease and what is our workforce availability? So global burden of disease comes from this really fantastic data set that is run out of the University of Washington, funded by Bill and Melinda Gates Foundation. It's a consortium of thousands of researchers from all over the world who have been collecting data since 1990. In over 150 countries, they've been cataloging various diseases and associated outcomes with that. And so I wanted to take a minute and just look at 2 conditions. We don't have time to go into all of otolaryngology, but I think 2 conditions can kind of highlight the fact that global otolaryngology, I think, is kind of a big deal. Okay, so hearing loss is the 4th most common chronic disease in the world. The prevalence of hearing loss is estimated at 1.2 billion. And hearing loss constitutes 1.64% of all disability-adjusted life years in the world. That to me, you can kind of brush over it, but if you actually think about it, in my mind, 1.64% of entire disability-adjusted life years solely for hearing loss globally is pretty astounding. And that's for untreated hearing loss. That's not considering people who are already being treated. So Rustin, you have your work cut out for you for sure. Great. And then what about head and neck cancer? So as of 2016, over 1 million new cases of head and neck cancer were reported globally, and the majority of those were occurring in low and middle income countries. And there were over 500,000 deaths, and 82% of those were occurring in low and middle income countries. And head and neck cancer constitutes 5.7% of all global cancer-related mortality. Again, fact or statistic that's pretty easy to brush over. But when I think about that, to me, that's pretty astounding because I always think of otolaryngology as being a relatively small niche subspecialty. But that 5.7% is effectively on par with breast cancer and significantly more than pancreatic cancer. Okay, so what about for the future? What's the prediction of head and neck cancer mortality and epidemiology? So there was this nice study that came out just about a year ago that analyzed data from that global burden of disease study. And they mapped mortality from 2016, and then they were able to predict and evaluate how mortality was expected to change And so this map shows predicted mortality changes. The darker red show increases in mortality, and the blue show decreases in mortality. So not surprisingly, we're seeing that the lowest income countries are having the greatest increase in mortality. The United States is expected to have some increase, but not as much proportionally. Okay. But what about, so that's overall mortality, but what about overall how patients are faring? So not just the actual number of people who are getting sick and dying, but how are they doing in terms of their treatment course and or prevention? So the study also looked at something called mortality to incidence ratio, where they divided the mortality by the incidence of the disease to give us a little bit of a sense there as well. A lower MIR would reflect a more effective cancer prevention or treatment program, and a higher MIR, the opposite. Not surprisingly, again, in the highest income countries, we're seeing pretty low MIRs compared to about 3 times that value in lower income countries. Okay. And then also, it's a little bit beyond the scope. Well, I wouldn't say it's beyond the scope. It's certainly very much within the scope of this conversation tonight. We just don't have time to delve into the details of the fact that, again, these disparities in head and neck cancer or global otolaryngologic outcomes, these are not unique to low and middle income countries. We obviously see this all the time in our own backyard and the patients that we take care of. For example, here was a recent study showing that lower income is associated with 50% worse overall survival and 40% worse disease-specific survival for all head and neck cancer subsites. And I'll just acknowledge Dr. Magwalu, who's kind of a big champion of this health disparities outcomes research. Okay, and what about the global otolaryngologic workforce? So there was a recent review that came out just in the past year looking at otolaryngologists around the world. And this was done by the World Health Organization. They evaluated data from 138 countries pulled from various resources to try to figure out exactly how many head and neck surgeons were available around the world. They found that more than 95% of high-income countries have more than 10 otolaryngologists per million, whereas 78% of low-income countries have less than 1 ENT per million. So just to look at this on a map, again, here the lighter shades representing 0 to 1 otolaryngologists per million, and the darkest shades, which we're seeing mostly in Europe, are representing greater than 10 otolaryngologists per million. To put that into context, 1 or less otolaryngologists per million would be effectively the same as 1 or fewer serving the entire city of San Francisco. And then comparing these two maps from these two different studies, I think also helps put this into context a little bit, where the highest changes in mortality that we're expected to see is also corresponding directly with where we're seeing the fewest number of providers. And so there was another recent study that came out in the past year evaluating this relationship exactly. So evaluating the proportion of otolaryngologists in a community, and then comparing that to that mortality to incidence ratio that we're talking about before. And they found that there was a statistically significant relationship between those two. And even when we're controlling for things like cancer risk factors like smoking and drinking, or income, GDP of a specific country, we're still seeing those relationships hold true, which I think kind of tells the obvious story that the higher number of physicians or otolaryngologists in the community, the better we are able to care for these complex conditions. So a lot of material, but global burden of disease and workforce, if I had to summarize it into a single slide, I'd say otolaryngologic conditions carry significant weight on a global scale. LMICs are disproportionately affected by otolaryngologic conditions, and that gap is expected to grow, and that the world's poorest countries need more otolaryngologists. Okay, so what about some common pitfalls and evidence-based best practices for global otolaryngology? So here was a paper that came out in 2015. It was a systematic review looking at any publications evaluating various sorts of charitable platforms for global surgery. I think they reviewed, a review of over 100 publications. And so the authors found that they were able to categorize charitable platforms into 3 major types. 2 were temporary and 1 was permanent. So the temporary ones were short-term surgical trips, which are what we commonly refer to as mission trips. And then the other are self-contained surgical platforms. Oops. So that's something like Mercy ships, for example. So that's like where you have a floating hospital or an airplane that may come in, pull up to a certain port of call, provide all their own workforce, all their own infrastructure, stay for a set period of time, and then leave. So those are two. And then the third type is permanent specialty surgical hospitals. And so they evaluated the effectiveness, cost effectiveness, sustainability, and training associated with each of these three different platforms. Overall, they found that charitable platforms help fill an important gap in care, but that some platforms are more effective than others. So we don't have to spend a ton of time going into this because I think that the findings are kind of what we might expect. They're pretty straightforward, but I think they're still worth just mentioning briefly. That the longer term surgical specialty hospitals were generally seen as more effective, cost effective, and sustainable as opposed to the shorter mission trip style trips. Also, one thing that I thought was kind of interesting from the study was they talked a bit about effectiveness, and they found that some of the short-term trips tend to be less effective, even when run by physicians who are like very high volume and have very good outcomes in the United States or in their country of origin. That the outcomes tend to be not as good wherever they're working abroad. And their argument for that is that there's been a lot of research that has shown that not only do you need high volume surgeons, but you also need high volume institutions, that both those things together produce best outcomes. And so if you're doing these short-term mission trips, they're not really having the same sort of like high volume output. That article raised some ethical considerations that another article that came out recently spent a lot of time going into, and I thought was a very compelling piece and really interesting. And one of the things that I thought was super interesting about it was if you look at the author list, this is kind of like a who is who in the world of head and neck surgery and global otolaryngology. And it was very interesting to have a piece coming out from them talking about some of these ethical considerations. I think it carries a lot of weight. And I'll just kind of caveat and preempt this saying that this is their attempt to kind of be introspective and consider their outreach efforts. And it's by no means like an intent to negatively categorize these trips, because I think they're obviously all huge proponents of it, and I am as well. And I think there's a ton of value in short-term temporary trips, but I think that there are a lot of ethical considerations to take into account as well. So for example, some of the things, basically what they did was they did a survey of head and neck surgeons. I think they surveyed like 30 different surgeons and asked them to respond about their thoughts in respects to their own experiences on their outreach trips. And so some of the things that they came up with were cost considerations in terms of taking OR time away from local surgeons, supplies, and anesthesia and nursing staff away from local communities. It talks about some of the inadequate follow-up, lack of sustainability, and potential to undermine local physicians and undermine credibility of local physicians. And they also talked a little bit about how they're not always providing the same standard of care. We talked about that earlier as well. So for example, in this survey, they found that the free flap failure rate was about 10%, which is over double of the free flap failure rate here in the United States. Obviously, the arguments that some care is better than no care is reasonable, but I still think that there are major ethical considerations about that as well. And then they also talked a little bit about resource allocations in terms of like, how do we prioritize charitable platform trips? Should we prioritize investing the greatest number of resources into the most complex cases? Or should we invest fewer resources into less complex cases and try to access more people? I think the resource allocation question is a really interesting one, and I want to just take a moment going into that as well. Because this is something that is also pretty new in the fields and came up just within the past couple of years. this idea of creating like resource appropriate guidelines. So we all have these guidelines that we're using here in the United States and Europe, are kind of like a lot of the leaders in making guidelines, like American Thyroid Association for or thyroid nodules and lesions. But translating those into other contexts can often be really difficult. So just a few years ago, the African Head and Neck Society partnered with a number of leaders in the endocrine surgery field here in the United States to publish guidelines specific for low resource settings. And Dr. Orloff was actually one of the collaborators on this project. And so I'll just share a quote from the opening of these guidelines. They say, without resource appropriate guidelines for thyroid nodules and cancers, domestic surgeons and even volunteer surgeons visiting from higher resource settings have little guidance with regard to best practice when working in limited resource settings. Failure to take resource limitations into account may lead to inappropriate surgery, over-investigation, or in the worst case scenario, even have life-altering or fatal consequences associated with unforeseen perioperative complications or postoperative sequelae. So, for example, some of the things that are mentioned in those guidelines are taking into account or considerations if fine needle aspiration is available, and the fact that access to ultrasound or imaging for surveillance may not be as routine. They also talk about like thyroid hormone supplementation, the fact that many patients in low resource settings may not be able to access that. And so that would obviously change how you have to think about surgically treating some of these diseases. And then one exemplary platform that I wanted to just take a moment and highlight is the fellowship program out of University of Cape Town, South Africa, which has one of my favorite acronyms I think I've seen in a while. It's the only head and neck cancer fellowship in South Africa, the only head and neck fellowship in sub-Saharan Africa. And then there was a publication that came out by the fellowship director, Johannes Fagan, about a decade or about 8 years ago or so, at which point they had trained 10 fellows, and all of those fellows had returned back to their home countries or home institutions. And they talked about how they had developed these educational initiatives with their past fellows. So after the fellow had completed the program, they kind of followed their lead and collaborated with them in terms of developing these 1 to 2 week educational initiatives at that fellow's home institution. And so just to share a quote from that article, again, kind of straightforward, but I think still important just to explicitly say. The most important thing that the authors have learned from their early experience is that the success of each individual workshop has largely depended upon the leadership of the fellowship graduate who has served as a point person in each respective country to best organize and optimize patient and physician participation. So effectively having your key stakeholder in the community who's invested in these projects and help to organize them along with you is crucial. I think the other thing as well that is notable about this platform is that they're really focused more on education and capacity building as opposed to direct surgical and patient volume and care. So again, large topic, briefly kind of boil it down onto a single page. Temporary short-term surgical trips can help fill a really important gap, but they do need to be carefully considered. And the best interventions tend to be those that are training focused, resource appropriate, and are developed in collaboration with or under the leadership of a key stakeholder in the community. Okay, so what does the path forward look like for global otolaryngology? So I think we can all agree that ultimately the goal has to be self-sufficient healthcare systems, but how do we get there? So we'll turn back again to that Lancet, the 2015 Lancet Commission report, which outlined some policy directives in terms of how we can get there. One thing, for example, that they highlighted was they made these key indicators. This is a series of like six metrics that we can try to collect data on and evaluate, and then also set goals for, so that we can create direct policy initiatives surrounding. And so I'll spend a minute just kind of going into these key indicators. The first is geographic access. That's the proportion of the population that can access a hospital capable of performing a C-section, a laparotomy, or an open fracture repair within 2 hours. There's nothing really special about those 3 procedures. They're just what's called bellwether procedures. So effectively, they give us an idea of if generally acceptable surgical care is available at a particular site. And so the 2030 target from the Lancet Commission was 80% of the population in each country with geographic access. And then surgical workforce availability refers to the number of surgeons, anesthesiologists, and OBGYNs per 100,000 people. The goal is to have at least 20 surgeons, OBGYNs, anesthesiologists per 100,000. Surgical volume is the number of procedures per 100,000. And the goal is at least 5,000, and to have all countries keep track of this metric. Perioperative mortality rate, as we all know, refers to the mortality of discharge before leaving the hospital. There's no specific perioperative mortality rate that was set as a goal for the 2030 target. More is just the goal to be able to start collecting this metric in all countries. And then the last two are economic, about the risk of facing either impoverishing expenditures or catastrophic health expenditures as a result of accessing surgical care. And the goal is for nobody to be faced with those circumstances. And so that number that I shared with you earlier, the investment of about 500 billion now to be able to save 20 trillion in the future, comes from these key indicators in terms of where we stand at the moment regarding these indicators and those 2030 goals. I did a bit of research to try and see kind of where we stand now, like an interval update in terms of these 2030 goals, and there's not really a ton in the literature yet about that. So I definitely think that there's some area for future investigation. And then this thing called NSOAPs have been developed. These are National Surgical Obstetric and Anesthesia Plans. These are country-specific national health plans that focus on surgical capacity and access. They're based on these 2030 goals and the key indicators from the Lancet Commission. So effectively, a Ministry of Health in a local country will come together, develop an NSOAP, and then institute it in at their home country. And since the Lancet Commission, a number of countries have come out and developed NSOAPs and started to put them into action. For me, I think this highlights a really beautiful transformation in the global health sphere in terms of thinking really big picture, researching, finding metrics and data, and then translating it directly into policy initiatives. So for me, I find this really encouraging. But again, how do we bring it back specifically to otolaryngology? So in the past year, this publication came out that was a consensus statement from a number of otolaryngologists looking at how to prioritize otolaryngologic procedures around the world. And so they did something called a Delphi method consensus study, where they recruited otolaryngologists from around the world. They made sure to have at least one representative from each UN recognized geographic area in the world. And they administered a series of surveys to find where consensus was the highest in relation to various procedures. And so they came to the conclusion that there were these 10 procedures that the experts agreed were kind of the highest priority. So these were a tracheostomy for adults, peritonsillar abscess drainage, an IND of deep neck space infections, pediatric tracheostomies, control of epistaxis, rigid esophagoscopies with or without foreign body removal, ear foreign body removal, drainage of periorbital abscesses, thyroidectomy, and excisional biopsy of neck masses. So I think this is one of the first times we've had a list like this. And I think it's kind of interesting because if we were probably to come together as a department or as a group in this room, we'd probably have a pretty different list than this 10, but this is intended to be representative of more of a global perspective. And it's one of the first times that we have a list like this that we can use to kind of similar to the Lancet Commission on Global Surgery, like a key indicator list in terms of evaluating otolaryngologic efforts to build surgical capacity in the world. How are we doing in terms of these specific procedures, training, and number of procedures being done? And then, so other areas for future research are region-specific needs, some conditions that need to be prioritized, and then how do we, in a cost-effective way, prioritize those procedures. Okay, so we're coming to the close here, and we'll talk just a little bit about how to incorporate this into our own practice. So obviously not everybody has the bandwidth to be able to partner with ministries of health to develop these NSOAPs. So on an individual and department level, what can we do? So I think that continuing with short-term surgical trips is especially those that focus on building long-term, longitudinal, and collaborative relationships, I think is certainly a really fantastic way to go. But I think that there are also some other takeaways, or at least other things to consider when organizing these sorts of outreach trips. One, as I hope I've pointed out, that this is global surgery and global otolaryngology. It's a new field. It's definitely filled with a lot of controversy and debates. But I hope I've also made the argument that it's an academic field, an academic discipline in and of itself. And there's a lot of room for research and research collaboration here. So the hope is, yes, while there has certainly been an emphasis in the past in terms of traveling and working abroad, you can also be engaged in these research efforts right here at home in front of your computer at your desk. I'd also say that when we're thinking about various sorts of either capacity building programs or outreach efforts, we should try to keep in mind the bigger picture. So let's keep in mind the Lancet key indicators. Let's keep in mind the global burden of disease and which diseases and conditions we should try to prioritize and focus on. And then let's also think about that Delphi consensus list of otolaryngologic procedures as well. And then I'd also say that technology and COVID have really helped us realize that geographic barriers should not be a barrier to intervention. So we've seen, there's been a number of research studies that have shown that remote surgical training is on the rise and definitely possible. So studies here in the United States, for example, have shown no difference for sinus surgeries, no difference in resident satisfaction and resident skill acquisition for cases, whether the attending surgeon was in the room or whether the attending surgeon was out of the room and watching and providing feedback over the phone or over the computer. I think if any of us have recently been in skull-based cases, we definitely see that all the time. And then from a virtual seminar perspective, when the University of Miami, for example, does biannual trips to Haiti to collaborate with the Department of Health or the otolaryngology program there. And during COVID, they obviously were not able to make those trips. They organized several virtual platforms and educational platforms that were a huge success for their department. And so a few other considerations for our department, things to think about, food for thought. So there are several ongoing global health outreach efforts in our department, all of which are really fantastic, but they're also disparate. So everybody's not working together as a unified unit. And so I wonder if it would be worthwhile to consider unifying it. So maybe like a task force to get those who are interested to try to potentially unify efforts, pool resources, and work together. I also wonder if it could be really interesting to try to establish like a sibling, brother or sister type OH&S department in a lower middle income country. I'd kind of envision this as residents and faculty partnering together to collaborate in research, education, surgical training, and peer-to-peer mentorship. I think the peer-to-peer mentorship thing and the relationship building aspect to me is like the most compelling part of a relationship like this. I try to do a pretty extensive literature review. I didn't see anything published on a program quite like this, but a number of other articles or some of the quotes I shared earlier have shown that those relationships and having those relationships with key stakeholders are kind of some of the most important aspects in terms of global health interventions. And so in my mind, if we're able to pair first year residents, interns together with interns at another institution abroad, they would kind of like come of age and grow up together in their training, and they would potentially have those relationships with them for a long time to come. And then I think it could also be worthwhile considering dedicated scholarship opportunities for visitors from low and middle income countries. We have researchers and scholarly visitors that come all the time. And so I think maybe considering having a dedicated set for those from low and middle income countries could be worthwhile. And then a few other tangibles. If any of these things sparked your curiosity or you're interested, there are a number of organizations that are doing research and work related to this. In particular, the Global OH&S Initiative, I really highly recommend. They're an online, totally virtual platform of otolaryngologists from all around the world that meet every couple weeks and are doing a lot of really interesting research. And then this coming Saturday as well, there's a talk that is being put on by the AHNS. It's Bridging Continental Divides, Challenges and Opportunities in Head and Neck Oncology Practice in Low Resource Settings. And they'll be partnering with a number of surgeons in low and middle income countries and here in the United States to kind of talk about their various pitfalls and opportunities and experiences. And then a few other acknowledgements of different faculty from across the country who've been really helpful and big mentors to me in this field. And then also our entire department here in the head and neck department in particular, who have been really just outstanding and supportive and who I'm very grateful for. Thank you, that's all.